In the given case study, Mrs. Brown has a history of heart failure, condition described as reduced contractility of left ventricle due to the myocardial tissue damage. This can be caused by various underlying problems, including myocardial infarction, ischemic heart disease, and hypertension. In the event of heart failure, cardiac output falls significantly due to the reduce in stroke volume. Stroke volume, defined as the volume of the blood pumped out by ventricle in each contraction. As a result, less blood will be ejected from left ventricle to the aorta in each contraction. When there is less oxygenated blood available for systemic circulation, there will be low blood pressure and it leads to negative impacts in tissue perfusion mechanism. When baroreceptors located in carotid sinus and aortic arch detects low blood pressure, or homeostasis mechanism will be activated to compensate low blood pressure and tissue perfusion. When sympathetic nervous system is stimulated by medulla, it expresses and secretes specific hormone called epinephrine and norepinephrine, causing stimulation of alpha-1 and beta-1 receptors located on blood vessel and myocardium respectively. Stimulation of alpha-1 receptors causes vasoconstriction of blood vessel, which influence blood pressure and tissue perfusion. Stimulation of beta-1 receptors located on myocardium promotes force of contraction of the heart by enhancing calcium movement. Similarly, when norepinephrine binds to beta-1 receptors, causes threshold to be reached more quickly. As a result, SA nodes fires electric signal more rapidly and the normal heart responds by increasing its rate, causing atrial fibrillation. Atrial fibrillation is often poorly tolerated by heart failure patients due to the functional and structural change in ventricular. When cardiac output falls significantly, there will be less oxygenated blood available, resulting reduced perfusion of the kidney, which stimulates renin-angiotensin-aldosterone mechanism. This compensatory mechanism releases renin from juxtaglomerular cells, an essential substance required in formation of angiotensin II. Angiotensin II is a strong vasoconstricting agent that increases stroke volume and arterial pressure as it increases afterload. On the other hand, angiotensin II is responsible in stimulating release of aldosterone and ADH by adrenal cortex and brain respectively. When combined stimulation act in kidney, there will be retention of sodium and water, resulting increase in blood volume and cardiac output. This action ultimately increases blood pressure as we seen in Mrs. Brown case. As the failing left ventricle is no longer able to pump out oxygenated blood efficiently for various reasons, including myocardial tissue damage, increase in preload, overstretching of the heart wall. The ejection fraction falls 40% or less, residual blood starts accumulating from each contraction in the left ventricle. The normal ejection fraction of healthy heart is between 55 to 70% and calculated by dividing stroke volume by in diastolic volume or preload. Over the time, pulmonary circulation can no longer pass through the heart efficiently. This results in congestion of blood into the pulmonary vein, which increases the hydrostatic pressure within the pulmonary capillaries. As the pressure increases, congested blood then leaks into the pulmonary interstitial fluid, causing pulmonary edema. Pulmonary edema thickens respiratory membrane, which alters the gas exchange process, and therefore, Mrs. Brown is experiencing severe shortness of breath or dyspnea. In such event, bilateral basal crackle can be heard during auscultation of lungs as it makes harder for air to pass through the bronchioles into the alveolar and vice versa. It gets worse when the patient lies down because fluids spread all over the surface of the lungs, which makes gas exchange process even harder. Therefore, patient with congested heart failure recommended to sleep in elevated bed or sit upright as much as possible to allow gas exchange as fluid goes down due to gravity. According to Panola and McDonald's 2019, when the poor ventilation continues, it affects the gas diffusion process between air space in the lungs and bloodstream, causing hypoxemia, as presented in Mrs. Brown case. Such hypoperfusion sensed by chemoreceptors send feedback to respiratory centers to increase rate and depth of respiration.